My name is Sandy, and I'm the runner-up for the Student Voice Essay Competition this year, which is why I'm here. Today I plan to talk to you about who I am and a bit about rare disease teaching in medical school. I also talk to you about the Student Voice Essay Competition and my experience with the competition and talking to a patient with FOP, which we've kind of heard about before the break, and their caregiver as well. And then 3 lessons that I've learned and some final thoughts. So who am I? I'm a final year medical student, and I would say I probably have more experience with genetics and rare diseases than your average medical student. And this is not to blow my own horn, by the way. It was all an accident. So after my 3rd year of medical school, I went into intercalate, and for those of you who are not familiar with the term, it's essentially when medical students take a year out to do another degree. At the time of my application, my university started a new intercalated degree in medical genomics. And they said they only had 6 spaces that year and that it'd be very competitive. And because I'm very you want what you can't have type of person, I applied to it and left it at that. A few months later, I got accepted and got assigned a supervisor for my dissertation, and everything was going great. I was thinking, oh my God, it must be amazing, so I've got that. And then after signing all the paperwork, I asked my supervisor, so who else is doing this degree? And she said, oh, I thought you knew. No one else even applied? So, yeah. Shocked is an understatement, and I really started to doubt my decision. Why did no one else apply? I asked myself. Looking back, I think this goes to show how little engagement with genetics and rare diseases there is in medical school. It was too late to change anything at this point, but I'm very glad that that's the case. Okay, so a bit about rare disease teaching in medical school. So sadly, genetics and rare diseases are seldom taught in medical school. We have a few lectures in the preclinical years that go through, say, modes of inheritance, some notable genetic disorders. We also have a couple of sort of examples in every specialty that we do in the clinical years. But we get no rotations in clinical genetics, and we get no teaching on how to recognize a patient with a rare disorder and how to go about investigating or managing this patient. A lot of my friends and a lot of medical students see genetics as very complex and actually very low yield for exams. So actually, you're going to spend a lot of time studying it to be able to understand it, but only like 3 questions will come up. So it's not really worth the effort. So some people don't bother with it, sadly. So a bit about the Student Voice Essay Competition. I got involved with the essay because around this time last year I attended an event at the RSM which was run in collaboration with Medics for Rare Diseases who are here today. And it was a brilliant event and it was full of amazing speakers, and one of those speakers was the winner of the Student Voice Essay, and he spoke about his experience with the essay and what he'd learned from it. I knew I wanted to take part, so I put down a reminder in my calendar to check the websites that following year for when the competition reopened. And for those of you who are unfamiliar with the competition, it essentially opens for 6 weeks and it poses 3 questions, and you get to choose whichever question you want to answer and you go from there. I believe you can submit 3 essays to all 3 questions, but that's quite a dedication. I'm not sure that's happened. No? Okay. And the 3 questions, those are the 3 questions that were there. There was about the diagnostic odyssey, there was the inequities of healthcare provision in rare disease, and there was also about mental health in rare disease. And I chose to write about mental health because it's something that I felt was crucial for me to learn and understand. So a bit about my encounter. So I was introduced to a patient, let's call him Sam, and his mum, let's call her Natalie, through FOP Friends, which is a charity that supports research into fibrodysplasia ossificans progressiva, FOP, which we've kind of talked about a bit before the break. Just to recap, it's an ultra-rare, progressively disabling disorder, and it affects about 1 in 1 million or 1 in 2 million people. And patients with FOP, connective tissue like tendons, ligaments, and muscles gradually turn into bone. It's usually manifests in childhood, and people describe it as having a healthy mind locked inside a frozen body. Sadly, it's not really that well understood, and there is no sort of cure for it. So we kind of talked about potential therapies, and so far it's sort of symptom relief that people focus on. And sadly, the life expectancy is around 40 years. Sam and Natalie discussed several barriers to accessing services and how it fell to Natalie to coordinate her son's care. She spoke about her difficulties in navigating the healthcare system often getting no responses from service providers or having to travel several miles for specialist input. Regarding consultations, they felt information was seldom shared effectively between specialties and local services. She highlighted her relentless fights for funding in an increasingly stretched NHS, whether this is for Sam's personal care, mobility or off-label use of drugs in an attempt to alleviate his symptoms. This was only exacerbated during his transition from paediatric to adult care, and it was evident that there is a lack of holistic, patient-centered approach to Sam's management. Now, the chances of coming across a patient with FOP are admittedly extremely low, but rare diseases as a collective, as we all know, are common. Nearly 8,000 diseases have been identified and they affect about 1 in 17 people. And therefore, encounters like this one in a person's medical career are actually inevitable. Clinical presentations vary, but the emotional burden they pose on individuals are comparable. I'll attempt to highlight key lessons that I've learned from Sam and Natalie, and from some discussions that I'd had with some medical personnel as well after, and from their FOP charity. So the first lesson is about the demoralized patient. Now, FOP creates pain, and pain is demoralizing. It creates disability, bodily disfigurement, social isolation, a medium for being bullied, feelings of dependency, perceptions of being a burden, all of which are also demoralizing. The susceptibility to demoralization differs between people, but even the most resilient have their breaking points. Demoralization in patients with rare diseases seem to encompass the fundamental psychological elements of disempowerment and subjective incompetence. For example, through the inability to function at one's previous or expected level. It creates a sense of futility through knowing the medical situation, and by virtue, the functional implications are never going to end. Consequently, patients feel hopeless and helpless. I think it's vital to make the distinction between demoralization and depression, because those similarities exist, like disturbances in appetite, sleep, energy level, and even suicidal ideation. In demoralization, there is usually preserved responsivity of mood. That is, as adversity ceases, the patient's capacity to feel enjoyment and to hope is quickly restored. And this is not to say that demoralized patients cannot develop depression and anxiety. We know that nearly 70% of rare disease patients in the UK report depression, and about 80% report anxiety and stress. But I think, unlike depression, demoralization fails to show sufficient improvement with antidepressants. Instead, it is best tackled through mitigating the patient's physical or emotional stresses, as well as fortifying their resilience. With chronic conditions, demoralization often lessens as novel management plans are delineated and symptoms are actively being managed. And with terminal conditions, demoralization can be diminished when patients believe the doctor understands their concerns, acknowledges their suffering, and is capable of addressing their problems. Exploring attitudes towards hope and meaning in life, fostering search for a renewed purpose, and using cognitive behavioral therapy to reframe negative beliefs can be valuable. Some may even benefit from spiritual support or family meetings to enhance family functioning. During Sam's last rheumatology review, he was told by his rheumatologist, "There is nothing more I can do." Now, the demoralized patient needs a physician who perseveres. There is never a time when nothing can be done. The second lesson I learned was that carers and caregivers need care too. So a bit about Natalie. She is a single parent of 2, and she serves as Sam's primary caregiver. During our conversation, she emphasized the daily stress and frustration she faces and the need to always try and hold it together. This is compounded with a continuous need to advocate for her son to receive the care he deserves. Although recently matters have improved for FOP patients and their families in the UK through the development of an FOP team, the Royal National Orthopaedic Hospital in London, the reality is, due to financial, logistical, simply pain issues, help is not always sought. It becomes somewhat of a postcard lottery. Natalie's duty entailed coordinating her son's numerous and multifaceted needs, sacrificing hers in the process. I mean, as a parent, it is heart-rending to watch your child suffer or feeling there's nothing more you can do. And it is extremely distressing to think about the future, not knowing whether being a caregiver is a role which will span the course of your child's life or your own. The agony of dealing with your child's death versus the hardship your death will bring to your child. There is guilt over how well you're meeting the needs of other family members, which unfortunately translate to using respite hours to care for them instead of yourself. Sleep deprivation, chronic fatigue, aches and pains are just some of the physical consequences. Life is anxiety-ridden, your control of day-to-day events lost, your ability to provide for your family diminished. Sadly, Natalie is not alone. About 65% of rare disease caregivers in the UK report they experience depression, and about 90% report anxiety and stress. What we as doctors or medical professionals can do to alleviate the heartbreak caregivers experience is arguably very little, but we need to exhaust all options to make a difference. And then a bit about the transition process from paediatric to adult care. Now, the chronic nature of FOP, like many rare diseases, means that continuity of care is essential in minimizing complications and improving outcomes. Therefore, structured transition programs aimed at effectively moving young adults, like Sam, from paediatric to adult services are crucial in closing gaps in care. It diminishes loss of access to allied healthcare professionals previously available to patients and reduces loss to follow-up rates. We must address additional issues that arise from adolescence as well, including susceptibility to mental health deterioration, independent care behaviour, self-advocacy, self-esteem, sexual health and advice on education and vocational planning. So some final thoughts. Now, I was very privileged to be exposed to what is a snippet into the lives of FOP families. And there's a lot of issues, but it's important to acknowledge the incredible work that is done by the FOP team at the Royal National Orthopaedic Hospital in London, the FOP Friends charity who've been brilliant, GPs, local services, etc. Picker Institute nicely summarises patient-centred care into 8 principles, which are seen as integral parts of providing high-quality healthcare. Those include respect for patients' values, preferences, and expressed needs, coordination and integration of care, information, communication and education, physical comfort, emotional support and alleviation of fear and anxiety, involvement of family and friends, continuity and transition, and access to care. Upon reviewing these principles, it becomes apparent why Sam and Natalie and so many others feel that care is inadequate. When considering the different ways rare diseases can impact affected families, it's not surprising that they encounter problems with mental health. It's almost irrefutable that additional resources are required to enable them to navigate the physical and psychological struggles they face. Acknowledging suffering, understanding concerns, helping coordinate care, allowing for respite care for caregivers, ensuring a smooth transition to adult services are just some of many strategies we can employ. Thank you.